it is my great pleasure to introduce Dr. Desai. He has been our staff for now almost 17 years or so in my calculation, or maybe more. He graduated from India, did his fellowships at Hopkins, Harvard, and came to Cleveland Clinic and has been with us spearheading the hypertrophic cardiomyopathy, radiation heart disease, coronary artery disease, plus cardiovascular imaging, especially with CT and MRI leadership in the country as well as internationally. He is currently, as you can see, he is the director of our Hypertrophic Cardiomyopathy Center. This is a huge success for Cleveland Clinic because we are one of the top leaders in myectomy, hypertrophic cardiomyopathy treatments, and more recently with medical treatment of hypertrophic cardiomyopathy. There is a new drug that was approved, and I'm sure he is going to highlight and educate us about it. This was purely based on the study that Dr. Desai conducted and has been highlighted all over the media to say that how Cleveland Clinic spearheaded this particular research under the leadership of Dr. Desai. So this is a great opportunity for us to learn more from Dr. Desai about the hypertrophic cardiomyopathy. Milind, thank you for doing this grand rounds.
Morning, everybody. Thank you for coming, and thanks for giving me the opportunity. Here are my disclosures. So I think before I start, I have to acknowledge the folks who have been instrumental, including all my colleagues in cardiovascular medicine. Special shout out to Nick Smedera in CT surgery, plus other colleagues. I think we have to acknowledge where we have come from. Harry Lever and Bruce Lytle were the original folks who put us on the map. Our imaging labs, now with a lot of new research, I have to acknowledge Steve Nissen and the C5 research team, plus our prospective research and our registry. You're going to see some stuff that each and every one of the folks have helped. Plus the team that helps me on a day-to-day basis, Sue, Katie, and Barb used to be with us. A lot of work we've done is with trainees and faculty at all levels. High school students to junior faculty in this field, and plus the donors who help continue support the education, training, and research. So let's get started. We will do some simple math. HCM is thought to have a prevalence of about 1 in 500, and it is generally thought to be uniform across the world. Some folks say it could be as high as 1 in 200. So if you do the math, there are expected to be almost 1 million patients in USA. As of right now, we know about 100,000. That means 85% patients are not diagnosed, misdiagnosed, or certainly underdiagnosed. If you extrapolate this into the rest of the world, we are talking millions of people where the opportunity to not only diagnose, but to treat exists. So this is why there's a lot of excitement in this field, and new therapies always result in new excitement. Fundamentally, I am still an imager, and I will contend multimodality imaging is key to diagnosing hypertrophic cardiomyopathy, not only to establish the diagnosis, develop appropriate phenotype, but also help with differential diagnosis. We have to connect the dots of symptoms with the morphology and what you are seeing. So the symptoms could be due to outflow tract obstruction. Outflow tract obstruction could be due to basal septal hypertrophy. The fundamental name, HCM, comes from hypertrophic cardiomyopathy, but I'm going to show you it's not just about hypertrophy. You could have additional things like mitral valve problems, papillary muscle problems, or you could be symptomatic without outflow tract obstruction due to combination of diastolic dysfunction, apical hypertrophy, subendocardial ischemia, arrhythmias, etc. We have to have an understanding of what the risk of sudden cardiac death is in that given individual. And of course, this is genetically mediated for the large part, so we have to know what the implications are in that front. These are 4 different patients with HCM: big septum, big apex, concentric LVH, papillary muscle problem. Each one of them is HCM. So they come in very different sizes. Not all HCM is thick walls, and not all thick walls are HCM. So 2 examples. The first one is your standard garden variety, thick wall, systolic anterior motion of the mitral valve, outflow tract obstruction, posterior MR, large obstruction. Obviously, this person, treatment is simple. You do a myectomy. This patient was gene negative. What about this person? There's no hypertrophy. Still, there's a lot of SAM. This patient, we took care of him a few years ago. This is what got our alternate theories of why you could have outflow tract obstruction going. This person was gene positive with the same symptomatology. You cannot do a myectomy in this person. So we developed a new procedure. Dr. Smadira was instrumental in doing that, where he manipulated the papillary muscle. This has had a huge impact on our practice, our referral pattern. So it is important to have a tailored approach. You don't want to look like me. You want to look like Dr. Krishnaswamy when it comes to being dressed, right? Most of us will agree there. Amar's sitting there. So another aspect is recognize this is emerging. The apical hypertrophy is emerging as a major. Now that we know a lot about the standard HCM, the apical variant HCM is emerging, coming into focus. We know now that if you have apical hypertrophy, you have to work hard, look for apical aneurysms. If you don't look, you will not find. And why is that important? Because the risk of sudden cardiac death is 3-fold compared to if you don't have an HCM, if you don't have an aneurysm. So when you have an apical HCM patient, always be on the lookout. Expect in your report to say there is or there is no apical aneurysm. If not, if you cannot find, you need to adjust your views and you need to give contrast. A lot of new stuff is coming in the context of left ventricular strain. I'm just highlighting a couple of papers. This is a paper we did a few years ago on echocardiography, almost 1,000, 1,100 HCM patients, where we have shown that strain provides incremental prognostic value for hard outcomes. This paper was just published last week, I think, in JACC Imaging. Almost 2,300 patients who underwent cardiac MRI as a part of a multicenter registry, where we are now trying to understand, using 3D CMR strain, what some of the predictors are. The next step will be whether or not this adds incremental value in terms of prognosis. So a lot of stuff is happening in advanced imaging. A lot of stuff is happening in the context of this HCMR registry that we started along with Oxford and University of Virginia a few years ago now. Almost 2,800 patients who've been very well characterized. And now we are in the follow-up stage. So we will not only have diagnostic utility, but prognostic, whether or not it adds prognostic value or not. We are entering the era of artificial intelligence, machine learning, et cetera. This is, again, on 2,400 patients who underwent extensive phenotyping as part of the HCMR registry. This was published at the end of last year, where we are using different patterns, machine learning, to identify which patients may obstruct, patients may obstruct at stress, which patients what does the role of genotyping play in all this? So this field is the field of imaging, machine learning, and you put the disease, whatever disease, in this context, HCM, this is rapidly evolving. So a lot of stuff is going to emerge in the next few years. I have chosen to show this paper to highlight some of the potential pitfalls of going gung-ho on artificial intelligence. This is a paper published by another large center, which shows that using artificial intelligence, you can diagnose HCM with a very high degree of accuracy. The problem is 95% patients were Caucasian and majority were men. Most of us know that HCM has similar race preponderance, and in African American ethnicity, the ECG at baseline could have a lot of abnormalities that could be picked up as abnormalities that are not really abnormalities. So anytime we see a machine learning AI type paper, we have to look at you cannot just read the conclusions or the abstracts. You gotta go deeper into this. Some of the additional work we've done in collaboration in terms of machine learning, superior to assess wall thickness. This is something that we worked with the Heart Hospital in London. And this, again, this paper was published last year, where using just single view on cardiac MR, we can ascertain basically presence of obstruction. We can understand various aspects of pathophysiology. So a lot of exciting new stuff is happening in this context. Step 2, it is absolutely important to elicit outflow tract obstruction. If you don't look, you won't find, and if you can't find, you cannot treat. It is absolutely important. I'm highlighting this case of a young guy who, after seeing a couple of psychiatrists, was sent to us. The only reason he pursued cardiac evaluation because his mother had standard HCM. He was told that this is nothing going on. You put him on a treadmill, his gradient is more than 100. And he had all the symptoms that brought him to the doctors. Outflow tract obstruction versus no LVOT obstruction is associated with the worst long-term outcomes. So it is important that we recognize this and utilize all means to provoke outflow tract gradient. Without provocation, resting gradient is seen in 25% patients. With provocation, you can see it in 70% patients. That statistic alone should be enough for us to elevate our game. Designating somebody as non-obstructive HCM without full extent of testing is not appropriate in 2023. Stress echo can and does provide significant incremental value, not just prognosis, but also diagnosis. It assesses latent symptoms, functional capacity, outflow tract gradient. Again, a few years ago, we published this paper, 430 patients who came to the Cleveland Clinic saying they were asymptomatic with HCM. Prove it to us. We put them on a treadmill. Only 18% patients achieved what was expected off of them. Not all of them were just deconditioned and obese. A lot of them had symptoms that they did not realize. This is important. Third thing, this is what essentially a large part of our practice is, substantial part of our practice because of our experience with this. Recognize not only typical, but atypical variants of obstructive HCM. Majority of the patients are going to have the standard thick wall, outflow tract obstruction type HCM. But you will see a fair number of patients, especially in the Cleveland Clinic echo lab, where you have papillary muscle problems, chordal problems, mitral valve problems, etc. It is important to recognize this because management plan is different. Again, designating somebody as not having HCM because they do not have hypertrophy is not appropriate in 2023. You have to work to rule out other variants. These are 3 examples that we have seen in our practice over the years. The first one has a very long anterior mitral leaflet, no basal septal thickness. Everything else looks like HCM on Doppler. Bifid papillary muscles on MRI, no wall thickness. Again, severe outflow tract obstruction. Somebody with an abnormal chordal attachment. Again, severe outflow tract obstruction. None of these patients can have a myectomy because there's not much muscle to shave off. It is important to recognize this. Differential diagnosis is important because there's a lot of things that have thick walls or look like HCM. Using strain on echocardiography, we can ascertain some of the differential diagnosis. The top left is your standard HCM. Top right is somebody who has normal strain, except in the apex, that is most likely expected to be apical HCM. The flip side is the cherry on top, the apical sparing amyloidosis case that, again, was first described at the Cleveland Clinic. Using multimodality imaging, especially CMR and scar assessment, you can further ascertain, could it be Fabry's disease? Could it be amyloidosis? Is this athlete's heart? So it is important, when in doubt, to expand your thought process. If there's clues in history, you need to chase that. Having said that, sometimes life is humbling. This is our experience with almost 2,500 myectomies. All the patients were seen by expert cardiologists at the Cleveland Clinic, diagnosed to have hypertrophic cardiomyopathy, sent for surgery. We went back and looked at pathology. 1 in 5 patients had an alternative diagnosis. So even when we thought it was HCM, there was an alternative pathologic explanation. So look for clues and always look out for the pathology report after they've had their operation. Next step, all these patients have a problem with potential sudden cardiac death. So it is important to stratify their risk. There are 2 schools of thought, North American school of thought and the European school of thought. The North American school of thought is what all of us typically use: strong family history, massive LVH, unexplained syncope, non-sustained VT, now fibrosis on cardiac MRI if it is more than 15%, burnt out HCM, and here, LV apical aneurysm. This is why it is important to identify that. This is a risk factor. If you have that, you recommend an ICD. The Europeans do it slightly differently, where you plug everything in a formula. If your risk is more than 6%, ICD is indicated. If it is less than 4%, it is not indicated. Now, there's a comparison between ESC and American approach. The contention is number needed to treat using the American approach is lower, meaning we may help more patients with the American approach versus the European approach. Either way, no matter what you do, you need to risk stratify for ICD. How do you proceed with the thought process? If you've had a prior event, recommend it. If you have at least one of the following American criteria, it is reasonable. If not, look for non-sustained VT and scar on MRI. If you have both, ICD may be considered. Just to participate in sports, getting an ICD is highly inappropriate. Class 3. I would like to highlight this paper that we published. It's almost 1,500 patients. Amgad Mentias, who's now our junior staff, when he was a resident, we did this work together, where we have shown that a threshold of 15% of scarring off of LV mass is associated with a worse prognosis for heart events, no matter what the subgroup, total group, patients who are with obstructive, patients with non-obstructive. So this is one of the key papers that was incorporated into guidelines when they recommended 15% as a threshold. Screening. This runs in family. So genetics we will talk about in a little bit. but for sure, you need exquisite screening. Echo is the first line, but when in doubt, when there's a little bit more suspicion, moving to CMR would be appropriate. And obviously, it does a better job of looking for wall thickness and myocardial fibrosis, et cetera. So it is important to recognize the need for screening first-degree family members. I think I'm going to spend a lot of time now talking about management. Obviously, step one is you need to recognize the diagnosis, some lifestyle modifications, competitive sports, volume depletion, avoid isometric exertion. The business of exercise in HCM is rapidly evolving. There's going to be a late-breaking trial at ACC later this year, which will shed further light. So this space may change, but avoiding avoiding drugs like ACE inhibitors, ARBs, some of these calcium channel blockers. It is amazing how many patients we see even today who come with these drugs. We stop these drugs, they feel better. The gradient goes away. Screening for obstructive sleep apnea. A high proportion of patients have sleep apnea in this context. Sports, mild to moderate intensity recreational exercise is beneficial. In fact, it is recommended because otherwise patients get deconditioned. Athletes, you need to talk to an experienced provider, especially high-end elite athletes. Pregnancy, not an issue in my book. Comorbidities, a lot of people under-recognize the need to treat hypertension and obesity and all the other things. It is absolutely important for us to be dealing with this. Now, in obstructive HCM, there are no prospective trials, single or multi-center, comparing various FDA-approved medical therapies. In fact, there was no FDA-approved medical therapy before last year. Everything else was extrapolation of what we've learned from other diseases. No prospective data, invasive versus FDA-approved medical therapy. No prospective trials comparing myectomy to alcohol septal ablation. Recently, a prospective study was done in beta blockers, which improved gradients, improved symptoms, but did not do much to improve functional capacity. So pretty much all the guideline recommendations in 2020 guidelines are level of evidence C, mostly observational data and consensus opinion. Medical therapy cannot be worse than the disease. You have to be very careful about overzealous prescription of medications like beta blocker and disopyramide because they have side effects. Sometimes side effects are worse than the disease. Overzealous restriction of physical activity results in obesity, deconditioning, and all the bad things that come from that. Generic drugs and their suboptimal effectiveness is a real thing, and it needs to be recognized and adapted in your management plan. So when this becomes too much, you may need to move to the next step. The next step is typically septal reduction therapy. But as I've shown you in the previous imaging data, it cannot be a one-size-fits-all. Majority of the patients will benefit from a septal myectomy. Thick walls, shave the muscle, life goes on. But what if you have papillary muscle or mitral valve problem? You gotta get adaptive. If it's a mitral valve problem, fix the mitral valve. Papillary muscle, reorient the papillary muscle. It needs an experienced center with experienced surgical team. In fact, this is data from the Cleveland Clinic. Majority of our outflow tract obstruction surgeries involve myectomy plus minus something else. This is a huge part of our practice, national, international referral practice. What is our data? Almost 2,300 patients. As I said, 55% underwent isolated myectomy, the rest had combination procedures. We always have believed that patients, we should not be waiting for class 1 indication, but sending patients earlier if they have other reasons to do so. What we have shown is patients who get sent for an earlier operation have a much better longer-term outcome similar to age and gender matched population versus those who we are waiting for development of a class 1 indication. More importantly, a concomitant mitral valve repair operation or a papillary muscle operation does not add to mortality. It has similar outcomes to a standard myectomy. So there is a difference in school of thought between us and some of our friendly competition where we believe do a complete job of LVOT obstruction using whatever means necessary. And it may or may not just be myectomy. Quality of life. This is the SPIRIT-HCM study that we published last year. This was one of the earliest first prospective study in surgical myectomy. After surgical myectomy, the blue is baseline quality of life. After myectomy, the quality of life blew it out of the water. Significant improvement in all aspects of Kansas City summary score. So this remains the gold standard in terms of quality of life improvement. Alcohol septal ablation is an alternate process that can be applied in the Cleveland Clinic. We typically do this in patients who are not adequate candidates for septal reduction therapy. It requires appropriate anatomy, adequate size septum, and obviously no concomitant mitral valve problems and pulmonary hypertension. It is important to realize typically alcohol septal ablation results in right bundle branch block. If you have a person who has an inadequate alcohol ablation and they need a surgery, which typically results in left bundle branch block. So you are giving them buy one, get one free. The pacemaker comes for free. Not really. It comes. Class 1 indication, SRT should be performed by experienced operators for severe symptoms. Do a complete job. This is basically our research. This is our research. If you are symptomatic, surgery is not an option, then alcohol septal ablation. All these class 2B indication is driven a lot by our research. We have been sending patients for these operations, pulmonary hypertension, left atrial enlargement with AFib, poor functional capacity on stress echo, all these things. We've been doing this for years. Now they have made it to the guideline. Asymptomatic patients, class 3 indication. Try to save the mitral valve. Mitral valve replacement as a primary strategy is a bad idea and a class 3 indication. Now, there's more to managing these patients than SRT. The reality is we have 1,700 surgical myectomies and 800 alcohol septal ablations. So that means the remainder of them need to be treated using medical therapy. We have very good operators dealing with this. We need to start playing in this space. Where are we with that? But before we go there, expert centers have markedly better SRT outcomes, but there ain't too many of them. They recommend all the good things that need to happen after surgical myectomy if you go to an expert center. In an expert center, there is death 1 in 1,500, but if you go to a low volume center, 1 in 6 patients could die. Experience and excellence should be a habit, not an art. At least that's what Aristotle said. What is the reality? This paper just we published 2 weeks ago. What is the SRT landscape in USA? Again, working with Amgad, we did a large Medicare analysis, more than 5,000 patients across USA. Again, what we showed was myectomy had better long-term outcomes compared to alcohol ablation. Both SRT procedures reduce heart failure burden. SRT using myectomy had less reoperation. There was a good, strong, inverse association between experience, volume and outcomes, both for myectomy as well as alcohol septal ablation. But what is the problem? 70% of SRT procedures in USA are still done in low volume centers. 7-0. So there is an unmet need to increase the tent of available therapies. That brings us to cardiac myosin inhibition. Mavacamte is first in class. What basically it does is, we have to understand HCM sarcomere at its fundamental. There's a hypercontractile state, impaired relaxation, and altered myocardial energetics. The cross bridges between actin and myosin are not working in sync, and too many of them are present, and too many of them are not working in sync. So the heart is not functioning efficiently. Using mavacamte, it attenuates hypercontractility, improves energy utilization. It makes the heart function more efficiently. It has low arrhythmogenic potential. So this was first in class, developed as a precision drug to treat hypertrophic cardiomyopathy. In mice, it prevents disease progression, it prevents fibrosis, and it improves all the things we just talked about. So now we are entering the era of real prospective data, prospective randomized controlled trials. 2 phase 3 trials, EXPLORER-HCM in low acuity of symptoms, class 2-3 symptoms. Patients were on monotherapy with either beta blocker or calcium channel blocker. And the other one is Valor-HCM. These are significantly sick symptomatic patients on maximally tolerated therapy, including disopyramide, who were referred to expert centers for SRT. Each and every one of the patients was at their wits' end. They needed something done invasively. What did EXPLORER-HCM show? Again, 73% in NYHA class 3. So what this data showed is, compared to placebo, mavacamte significantly improved NYHA class and their functional capacity. It, without significant impact on the ejection fraction, it significantly dropped resting Valsalva outflow tract gradient, as well as post-exercise. It was significantly better than placebo for all primary and secondary endpoints. Additionally, significant improvement in quality of life, including 36% with a large improvement in quality of life. Significant improvement of biomarkers. In a small sub-study using cardiac MRI, it also demonstrated regression of cardiac mass, wall thickness, reduction in size of the LA volume, improvement in fibrosis. This is a small study, but a prospective study. So more to come in this space. This is altering the fundamental structure of the heart. Just last week, this was published. It improved, compared to placebo, all aspects of cardiopulmonary stress testing: peak VO2, peak METs, exercise time. No matter how you skin this animal, it was positive in favor of mavacamte. Long-term extension. Maybe this is just a short-term good thing we are seeing. Nothing happens in the long term. Not true. The gradient remains reduced. You can measure it at home. You can measure it in a core lab. No major difference. NYHA class continues to stay improved in the long-term extension study. That brings us to Valor study that we were fortunate enough to conduct and participate in. 92% patients were NYHA class 3. These were highly experienced myectomy alcohol septal ablation centers. We divided this into 2 phases. The double blind was for the first 16 weeks, where mavacamte versus placebo. Everything was done using real-life echo assessment. So symptom assessment and gradient assessment, physical exam and gradient. Everything done using core lab. After week 16, the placebo group crossed over to mavacamten and rinse and repeat. We did the same thing again. The question was, all these patients were referred to us for SRT. Will use of mavacamten eliminate the need for SRT in the short and intermediate term? What are the data? Primary endpoint was eligibility for SRT. At 16 weeks, remember at baseline 100% were eligible for SRT. At 16 weeks, only 18% remained eligible. At 32 weeks, only 11% remained eligible compared to placebo. NYHA class improvement, 91% improvement NYHA class 1. 30% improvement NYHA for at least NYHA class 2 compared to placebo where the numbers were not as good. 32% patients were on combination therapy, and 1 in 5 patients was also on disopyramide, so advanced therapy. When offered at 16 weeks and 32 weeks, 95% patients have chosen to continue medical therapy as opposed to going for SRT. What are some of the secondary endpoints? Kansas City summary score. In the mavacamten group, it reduces or it improves. This is the gradient. The gradient improves and stays improved. In the placebo group, it does not do anything for 16 weeks. At crossover, dramatic reduction. Same with Valsalva. Kansas City score improves at crossover time in the placebo group. Ejection fraction, no significant worsening in ejection fraction between placebo versus mavacamten. So safe and efficacious. Important, this is the story I think that will be evolving in the next few years. Biomarkers, significant improvement. Mass index regression, LA volume index improvement, troponin. Markers of diastolic function, including E over E prime. Everything trending in the right direction for mavacamten. This is a study, from our core lab led by Paul Kremer. Again, significant improvement in mavacamten arm for mitral regurgitation, as well as 1-stage improvement diastolic function compared to placebo. So it is changing the fundamental pathophysiology as it relates to the disease. This is an example of a patient that was part of our study, 71-year-old, prior failed alcohol ablation, remained symptomatic, unable to do activities of daily living on maximal medication. Look at the ECG, LVH with strain pattern. Resting echo, severe outflow tract obstruction. 32 weeks later, not only is the obstruction gone, but the ECG has normalized. The strain pattern on ECG is gone. LVH on ECG is gone. I've never seen this before. EF, as I told you, there is a concern. This is a cardiac myosin inhibitor, so the FDA raised concerns about the ejection fraction, but so far it has not emerged as a major story. Having said that, this drug was approved by the FDA under the risk mitigation program last year. You have to worry about ejection fraction as well as drug-drug interactions. This is our process that we have put in place. Once the patient is referred, we educate, we enroll them in the REMS program, we start Camzyos, our specialty pharmacy does benefits management. If they get denied, we write an appeal letter. So far, we've been very successful. Pretty much all patients, if approved, get on with the program. They will need periodic echoes for the first 3 months and then 12 weeks later. All this is placed by the FDA. This space will evolve once we have more comfort and data in terms of safety and long-term efficacy. Another drug is in development, aficamten. Similar thought process, similar data in terms of outflow tract gradients, hemodynamic response, and NYHA class. So a lot of new stuff is happening in this space. This is the next frontier, gene therapy. Using adeno-associated virus, we can manipulate the virus, especially for the specific MYBPC3 mutation in HCM. And what this can do is it can supplement the missing protein that is the hallmark of this particular type of HCM. So if this theory and therapy works, one-time injection in this genetically mediated HCM group will improve and eliminate the disease. We are in the leadership of this trial, and phase 0, which is looking at the immune response to this virus, that's already underway here, and we are soon to be starting the phase 1 trials in the next few months. So watch out this space. Obviously, we are going to have new logistic scenarios of safety, efficacy, but these things are evolving. Who will be doing, how often do we need EF monitoring? Who dispenses this medicine? Do they all need to come to main campus? Can this be done in the region? Can this be done in primary cardiology? What is the cost of medical therapy versus one-time cost of SRT? Would you have a suboptimal SRT at a less experienced center? Or if you have unsuitable anatomy, would you do that without a trial of Mavacamte? There's nothing in non-obstructive HCM. It's all extrapolation from other therapies. So obviously, and if things don't work, have a transplant. That's basically the guideline. There's early signal using Mavacamte in this population. Based on that, we have recently launched the Odyssey HCM trial. Again, this is started to randomize. We have already randomized a couple of patients. This is going to be led by us, Cleveland Clinic, myself, Dr. Nissen, C5, multiple core labs at the Cleveland Clinic. So this is rapidly evolving. If you have patients, please refer them to us. Managing arrhythmias. AFib is a nasty actor in this disease. Patients don't tolerate it. Success rate of ablation is less than 50%, and AFib is associated with bad outcomes. If you learn nothing else, just one most important thing. If you have HCM, CHA2DS2-VASc score does not work. If you have HCM, you have AFib, treat them with anticoagulation. Genetic testing is important. It should be considered. It should be offered to everybody. The problem is the positive yield rate is only 34 or 35% in this context. So you still have to do the rest of the things. This helps when it is positive. So how do you follow the cascade? If you are positive, then you test genetically. If the members in the family that are negative, they're done. The ones that are positive, they may develop the disease and you need to follow them. If they're gene negative, then you still need to do the imaging. There's SHARE registries, a large registry run out of Harvard, which is gonna be shedding some light about the implications and importance of genetic testing. But the point here is the buck should not stop if you're gene negative. Screening, obviously, kids, you need to frequently screen them. Adults, if they are gene positive, phenotype negative, or they have a family member, they need to be screened every 3 to 5 years. VANISH trial was published for early stage HCM, which has shown that in non-obstructive early stage HCM, using valsartan can slow the progression and development of full-blown disease. But it is important to make sure they don't have obstruction. Otherwise, valsartan will aggravate the problem. I believe pediatric HCM is the next big therapeutic frontier in this context. So I will conclude. The future is bright. Precision medicine will provide an additional option. It is providing an additional option. Remember, it is not about my pill is better than your procedure. Never about this versus that. It is always this plus minus that. how can you improve the quality of life of your patient? Because at the end of the day, it is about the patients. A well-managed patient in 2023 by an experienced team can expect to live a normal life with less than 0.5% mortality per year. So, to quote my favorite Albert, imagination is more important than knowledge. It stimulates progress and evolution. I think imagination is the most important aspect of scientific research. I'll thank you, and I'll be happy to take any questions.
Excellent presentation. And any questions from the audience first? Yes, Dr.
Milind, that was very exciting. What I want to ask you is about the hypertrophic cardiomyopathy of the elderly, how you approach this, any possibility with Mavacamte, and also HCM has been traditionally in other centers, some big leaders. How's the variability of HCM treated in the U.S.? You know, Barry Marin and others. What would you say?
So, first question is HCM in the elderly. So that is an important subgroup to recognize. So we've long recognized elderly patients with smallish cavity, elderly women, smallish cavity, and long-standing uncontrolled hypertension, they may develop this pattern of a septal bulge, a discrete septal bulge. It's called sigmoid septum, and then that can result in downstream development of LVOT obstruction. A couple of years ago, we presented our experience with more than 1,000 patients like this, where we definitely showed that relief using surgical myectomy was associated with much improved outcomes. Having said that, can mavacamten work, or can cardiac myosin inhibitors work in this context? I see no reason why they would not work. Now, the problem is, I think, how accurate are we going to be in ascertaining this is indeed long-standing hypertension? I mean, how often do you see uncontrolled long-standing hypertension do that? So, you know, if my educated guess would be the fundamental aspect of reducing hypercontractility would work in this context to relieve outflow tract obstruction. Now, the second question, a little bit more loaded question about how different centers treat diseases, this particular disease. I think, you know, obviously there are opinions, there are varied opinions. The big camps, the first thing is, you know, resting versus provocation in terms of, so now I think everybody's in the same boat. Everybody should at least offer provocation. The next thing is myectomy versus alcohol septal ablation. Remember, there's no prospective trials, okay? Having said that, the data is relatively convincing that surgical myectomy does result in more complete relief of outflow tract obstruction. Again, there are two major camps, Europe versus North America, related to that. Now, we have the new kid on the block. So with the new therapies, obviously there's going to be some trepidation. Rightfully, there should be as to who, where, how, why, all those things. And I think, you know, with time, people will be rowing, you know, all the cross bridges will be reduced and they'll be rowing in the same direction. The contention that you should, yeah, it's good that if you have HCM and you need surgery or an advanced procedure, you should go to an experienced center. That's fine and dandy. Is that really happening? That was the genesis for my thought process when we did that Medicare analysis. It's not happening. 70%. You can talk about going to an experienced center till the cows come home, but 70% patients are not going. So guidelines, we have to do a better job of marketing. We have to do a better job of advocacy. We have to do a better job of making sure the guidelines are adhered to. Guidelines state, go to an experienced center. 70% people don't. So it's always an evolution.
That's great. There is a question from the audience on the online. And the question is to say that if you have a patient who is phenotype negative and genotype positive, what is your imaging and follow-up on those patients? So the idea is that you are phenotype negative with genotype positive family members.
Yeah. So at the very least, we would recommend an EKG and a comprehensive echocardiogram with provocation. Now, sometimes a lot of these patients then come, I have vague symptoms. I don't know, maybe I'm having chest pain. Somebody heard a murmur. If they're totally asymptomatic, I will do EKG echo with strain. If there's some symptoms, there's some clinical sense, then I may expand it to a stress echo, and perhaps I'm having palpitations. Okay, you get an MRI. So for sure, EKG and echo. Now, if they are stone cold normal, I recommend them come back in 3 to 5 years. The other important group to think about is somebody gets a gene tested today and they are gene negative. What I tell them is please check back with us in 3 to 5 years. Every year, every day, newer therapies are evolving, newer mutations are being recognized. So you may have been negative 5 years ago. Now we may have stumbled upon something new. So generally 3 to 5 years is when I would bring them back.
One more question from me to say that there are patients who have outflow obstruction on provocation. The septum is not thick. And the question is that do they really have HCM or not? Because all the testing for the MRI and everything else is obviously negative, and they may or may not have symptoms. So what is the follow-up, and what kind of things do you suggest for these patients? Because this is a fairly large number of patients that.
So that's, so we have to take it one step ahead in the thought process and look at it as the syndrome of LV outflow tract obstruction with or without hypertrophy. So if you have bona fide no hypertrophy, you are gene negative, don't look like HCM, scar, everything else is okay, but all you have is outflow tract obstruction. And if you're symptomatic, you still have to treat them. You have to treat them with the standard lifestyle modifications, beta blocker, et cetera. I would not venture out to say give them Mavacamte, because Mavacamte was not studied in people with no hypertrophy or mitral valve papillary muscle problem. So for sure they need to be treated. And if they are maximally tolerated treatment, still symptomatic, still impaired function, quality of life is an issue, then we have sent patients like that for mitral valve repair or papillary muscle type reorientation. The important thing there is we got to be sure that we are going to help them, because I always counsel them, careful what we wish for, because in this situation, if the repair doesn't work, you may end up with a valve replacement. And often these folks are younger, they may end up with a mechanical valve. So it's one of those careful what you wish for type situation. If they have good capacity and they have obstruction, I would just bring them back. I would delay the procedure as much as possible.
Any other questions, comments? This is outstanding presentation, Milind, and
thank you.
Thank you everybody for joining. We have a large group of people online too. Thank you.